For session 4 of track 1 presentations, we have Dr. H. Stephen Sims to discuss physician wellness coupled with diversity and inclusion. Dr. Sims attended Yale College, Yale University School of Medicine, and completed his residency at Yale-New Haven Hospital. After a research fellowship at NIH in Neurolaryngology and Voice Disorders, he completed a clinical fellowship in Laryngology and Care of the professional voice at the Vanderbilt Voice Center. He is currently an associate professor at the University of Illinois Eye and Ear Infirmary. During the Obama administration, Dr. Sims was appointed to the advisory board for the National Institute on Deafness and Communication Disorders. His areas of expertise include neurolaryngology, gender confirmation voice procedures, laryngeal robotic surgery, and performing arts medicine. Please welcome to the virtual summit stage, Dr. H. Stephen Sims.
Thank you so much. It is a pleasure for me to be here in this lovely October weather. And I would like to talk today about physician wellness and coupling some of those concepts with diversity, equity, and inclusion. And that's been an area of great interest for me. And so I just want to share some of my thoughts about that with you and hopefully inspire people to think differently or expand some of the thought processes about how we approach these topics and how we really seek to integrate them as we are focusing on our holistic approach to physician wellness. Give me just a moment and I will share my screen. Okay, so this afternoon we will be talking again about physician wellness and coupling those concepts with diversity, equity, and inclusion. Just to tell you a little bit about me, I am an otolaryngologist and the director of the Chicago Institute for Voice Care. I grew up as a singer and performer, and my career is a reflection of that, and I take care of singers and professional voice users. But today, we're talking about physician wellness. So what are some of our objectives? Well, first, we want to define physician wellness. And then we want to look at what people think about when they discuss diversity, equity, and inclusion. And then we want to try to bring those concepts together as best we can and have an inclusive, holistic integration of these concepts into how we implement physician wellness and take better care of our caregivers. So looking at some of the published literature, what do we mean? Well, Dr. Brady, when she published about this, basically understood that in the same way you see a diverse representation of people here, the conceptualizations of what it means to have physician wellness can vary quite widely. And so I think we do need to have a bit of clarity and consensus really in what does it mean to be well? What does one need in order to feel well? I think all of us want to be holistic in this approach, but even within that, those terms can have different meanings. And so we do want to dive into that and explore it a little bit. I think one of the important things to consider and think about with that is what is the physician workforce? Who are we talking about? Again, this is a diverse group of people. However, in 2021, it is still predominantly white, over 50%, and predominantly male, over 60%. And so we always have to be careful about respecting and acknowledging the minority voices because there certainly will be a majority culture, a majority plurality that will have interest and perspective, and we don't want that to completely drive what we think about when we think about physician wellness. And just being putting a more fine point on that, the things that may help a Caucasian male to be well in medicine may not be at all the things that a Hispanic woman needs to be well in medicine, or a black man needs to be well in medicine, or an Asian needs to be well in medicine. And I think, again, that when we look at these demographics, there are still heteronormative approaches that come into this, and so we have to be as expansive as we can when we consider physician wellness and look at diversity, equity, and inclusion. So what does it mean to be well? Well, there are great conceptualizations of this, and so I want to go through these 7 real dimensions. I know there are 8 circles here, but the last one is an integration of these concepts. So we want to quickly run through these 7 dimensions, but I then want to share just some of the ways in which a diversity, equity, and inclusion lens helps us focus on how we create wellness, or how we even envision wellness in each of these dimension and realms. So spiritually, we all want to have purpose, and we want to feel like our existence means something. And one way to conceptualize this is the concept of shalom, which is not just the absence of war, but real peace and contentment, and the sense that we are enough as we are. But when we apply our DEI lens to that, we have to understand that there has been a development of Eurocentric spiritual iconography, and a way in which spirituality has even had some bias really imparted to it. And I think one of the important examples of this is our Native Americans, and how their spiritual practices and norms were very much rejected historically. And so as we begin to try to cultivate spiritual wellness, we have to be as inclusive as we can, and also recognize some of the history here that may make people less trusting, less likely to engage in some of those practices. Then we move to the physical dimension. And again, this encompasses the diet, nutrition, but also our physical safety. And I think that a lot of this has specific concerns for physicians when we think about how we don't take care of ourselves. We don't always eat as well as we should. We don't always exercise as much as we should. I think these are very important concepts, and our wellness program should address these and consider these. But I also think that we have to think about particularly underrepresented physicians who may come from neighborhoods where food deserts are common, where safety outdoors may not always be protected. These things really are considerations, and even some of the advice for physicians to go outside and take a walk, or go outside and get some exercise. I think we do have to be mindful of the fact that by choice, sometimes to stay with family, some of our physicians will still be in neighborhoods where outdoor safety is not absolutely guaranteed. And so we have to come up with strategies that take that into account, and are mindful of that, rather than just suggesting, go outside and take a walk. In terms of the emotional level, we often conceptualize this as being able to feel and honor and name our actual emotions, and be okay with that, and sort of rest in that space. This also really allows us to build some self-esteem and have some self-acceptance. But again, with our DEI lens, often for marginalized groups, the self-care is probably at the bottom of the list. There are so many ways in which we feel compelled to prove ourselves, and create a space for us where we fit in, that we are not centered, and we are not trying to center ourselves. We are really just trying to fit in. And so our emotional well-being really starts off in a different place than a lot of our colleagues. And so I think we always have to be mindful of that, as we begin to try to rectify some of the things that erode our wellness in this profession. Then we move to the environmental realm. In many ways, this is sort of that big picture initiative where we look at how we function on the planet that is given to us, and things like sustainability, environmental protection, and understanding our role as consumers, and perhaps what the limitations of that should be. And again, this is obviously important to overall physician wellness. But the DEI lens here informs us that environmental racism has really played a large part in the development of the community and the shaping of the community. And so there has been a disproportionate benefit to affluent, mostly white neighborhoods, and a visible, disproportionate detriment to poor Black and Latino neighborhoods. And so we do have to be mindful of these underlying forces as we begin to look at how we create wellness. Moving along in these 7 dimensions, occupationally, the idea that our skills, our talents, our gifts are optimally aligned with purpose and opportunity so that we feel good about what we're doing. But there's a great degree of bias that is rooted in race, gender, sexual orientation, and ableism. And all of this really thwarts who enters into medicine and feels comfortable and accepted and included in this enterprise. And so again, the way in which we recruit, the way in which we develop people to go into medicine has significant implications into the type of wellness and the degree of inclusivity we have when we look at wellness amongst physicians. Intellectually, like maintaining the peak physical condition, our minds need to be stimulated and challenged, and our overall wellness sort of depends on us being able to use our resources to expand our knowledge and improve our skills and feel good about what we are doing. But I think that one of the unfortunate currents that has happened historically is that eugenics and the idea of a superior race really developed concurrently along with any aptitude testing and things to sort of assess and appreciate intellectual prowess. And so we have these biases sort of baked in, and you have physicians who have proven an intellectual track record who are underestimated, who are underappreciated, and these factors necessarily erode the sense of wellness and belonging that some physicians may have in the scope of their practice and their interactions with colleagues. So again, these are just some of the ideas that are important for us to consider when we try to think about physician wellness. And then the last one of these 7 dimensions is the sort of the social one. And this is the idea that we are not islands, we are interconnected, and we need to rely on and work with one another in order to have wellness and success. And so our ability to communicate and interact and build relationships is an important aspect of our being. This is actually one of the areas in which the very nature of being marginalized and being in a minority and often being the 5% or the 3% or the 1% or the less than 1% almost creates an obligation that one builds networks and creates community so that one isn't alone. And so the ideas surrounding social wellness often lend themselves to the minority physician. And so our diversity, equity, and inclusion initiatives often turn on the fact that we want to be in the community, and we build these networks and coalitions. And so this is one of the arenas where actually wellness in this aspect is often in pretty good shape for a lot of these physicians. And then we want to try to look at, when we think about wellness, how do we pull all of this together? And our framework of physician wellness should be trying to think about all of these things. And so we should have the holistic integration of all these dimensions, fueling the body, engaging the mind, and nurturing the spirit. And while we're thinking about that, we also have to be mindful that racism, sexism, Islamophobia, systemic bias, and all of the ways in which we as a society often build barriers between ourselves really thwart the way in which we have true integrated wellness. And it's okay to understand that, because that just equips us to be mindful and thoughtful when we come up with strategies to figure out a way to have wellness for everyone. And that is, of course, a part of the goal that we want. But after sort of laying out what are some of these dimensions of wellness and what do these things look like, and also laying out some of the ways in which some of our social ills that relate to diversity, equity, and inclusion have always come against the idea of us having complete wellness for everyone. Let's try to move a little bit more into what happens when DEI meets some of the wellness that we would like to try to be able to create. So one of the things is we start by trying to understand, what do we think about these concepts of equality, equity, and reality. And so this cartoon is often used, and it helps us understand that there is an equality in giving everyone the same size box upon which to stand. But you see that being equal in terms of what you distribute does not create equity, because we don't all need the same thing. And that sort of relates to what I was saying in the beginning about looking at the demographics of who is in medicine. Not all physicians need the same thing to experience inclusion, equity, and wellness along with it. And so we do have to think out of the box and listen to one another in order to determine really what should be in the scope of things that we provide in order for everyone to have a sense of wellness. And so you see here that needing a double stack might be what someone requires in order for them to enjoy the same experience as someone not needing anything at all, because they stand tall enough to already see this. And then the other concept here that I think is sometimes difficult for us to wrestle with is, in reality, there are people who, not necessarily through any actions of their own, but historically benefits have accrued to them. And I think that this is this idea of privilege, which people often have a very difficult time with, because it feels like it's a condemnation. If you have privilege, that means you don't work. If you have privilege, that means things were handed to you and given to you and you didn't earn them. And I think that that is a misconceptualization that I do understand. But what it really means is that the world is built a certain way. And if the world is built to favor someone who happens to be like you, you will enjoy that privilege whether you want to or not. And for me, even as an underrepresented minority, I certainly had to come to grips with the fact that I do enjoy male privilege. And there are things that what is considered natural leadership is often framed in masculinity, or these concepts that we have developed and called masculinity. And so the idea that as a male I am more apt as a leader is something that benefits me whether I worked for it or had anything to do with it or not. And so I do have to own and acknowledge that there is some benefit that accrues to me from that. And again, it doesn't mean that I didn't work hard. It doesn't mean that I haven't earned any of the things that I've achieved. But it does mean that there are few times when me being male made it harder for me to assume a leadership role. And again, these are things that we have to be honest about and own and move forward. But as we are trying to develop wellness, some of this is just some self-searching and self-acknowledgement and understanding where we are in the great sphere of things and how we move forward. Perhaps even being able to share some of our privilege or to use some of our privilege to invite more people into the discussion with us. And so in that vein, I want to look at sort of two important concepts from diversity, equity, and inclusion that threaten wellness. The first one is microaggressions. And the second one is, I think, more newly emerging, which is weaponizing resilience. And I just want to talk fairly briefly about these two concepts, just to put them on the table, then move us along and wrap up. So I don't want to be before you too long today. Microaggressions, what are they, and how do they function? We can thank our two pioneers for this. Dr. Chester Pierce really began this work in the 1970s. When he began it, it was almost exclusively to African Americans when he coined the term microaggressions and began to speak about this in terms of what Black people specifically were experiencing with anti-Black racism. Dr. Sue really expanded those concepts to include all manner of underrepresented and marginalized people. And I think that today there certainly is the idea that microaggressions can happen to anyone, and so even people in majority culture can experience microaggressions, and that is real and that is valid and that should be acknowledged. But I think if we consider the mosquito bite analogy, which is one of my favorite to sort of conceptualize microaggressions. If you get a single mosquito bite, it probably doesn't bother you that much. You brush it off, it may itch, it may swell a little bit. It's a bit of a nuisance, typically a very small nuisance, but not something that really derails your day or requires your attention or distracts you greatly or really shifts your focus in order for you to marshal some resources to help with that. But if you are bitten 100 times a day, 365 days a year, then that becomes something different. And so again, I do want to acknowledge that everyone can experience a microaggression, but the onslaught of microaggressions that can really slow people down and really erode their sense of wellness is more likely to be experienced by someone in a marginalized group. Thinking along those lines, let's look at the definitions of microaggressions. What are they? Again, they're not just racial, but the initial conceptualization was racial microaggressions. And so these are sort of the commonplace verbal or nonverbal indignities that, whether they are intentional or not, they communicate a derogatory or negative environment, and these are things that would be perceived as a slight or an insult. We can divide these into three different categories. The micro insult, which are the remarks, things that could often be considered or excused as rudeness or insensitivity or lack of sophistication, those types of things, but often are rooted in someone's identity, heritage, culture, those types of things. Then the micro assault is a bit more explicit but it's characterized by the verbal or nonverbal attack. But this is a bit more intentional. It's meant to hurt the victim. There is a pointedness to the name calling or the idea of ostracizing someone from the group. And then the micro-invalidation, this is sort of that backhanded compliment. They exclude or negate people based on their personhood, culture, race, sexual orientation, etc. And these again are things that it's death by 1,000 paper cuts or death by 100 mosquito bites, because the onslaught becomes daily and so pervasive in that way. And then each of these sort of three areas or arenas that we define can create a culture or an environment of microaggressions that, if tolerated, really feel like a macro level problem and an environment that is hostile to persons. And when we look again at physician wellness, the culture amongst physicians has long tolerated degrees of microaggressions. And again, we are still in this transition from a profession that was very highly dominated by white males, and we still have diversification and entry of different looking, different behaving people from different cultural backgrounds, and the way in which we are truly trying to define this melting pot and have a culture that is accepting of all of it is still a work in progress for sure. And so again, I want us to be mindful of that, and how the microaggressions that exist have to be addressed in any scheme that allows us to try to create and promote physician wellness. Sort of defining what they are, and even though I do talk about the mosquito bite analogy, there's actually real harm that comes from these. And so I just want to run through a few studies that look at the physiologic changes. And so there's a trauma response that comes from experiencing microaggressions. And you get elevations of tumor necrosis factor, you get elevation of interleukin-6, cortisol, both in the serum and the urine. And this has physiologic effects. There is a trauma biology response to experiencing these microaggressions that erodes health. It suppresses the immune system, it increases blood sugar, it decreases serotonin. So there are real consequences to the microaggressions that people experience. Another study, looking at chronic health conditions among Asian Americans. They looked at almost 2,100 Asian Americans and did a survey of some of their chronic health conditions and also some of their experiences daily with discrimination. And they found that there is a clear correlation between the discrimination that people experience and tolerate and cardiovascular, respiratory, and pain conditions. So again, very real health detriments associated with these microaggressions. One of the important studies looking specifically at physicians began quite some time ago, and actually I think this is a great study in terms of the longevity and how long they looked at this. Thomas et al. Published this in 1987 in the Journal of Chronic Disease. They looked at cohorts of physicians at a historically black medical school, Meharry, and at a preeminent white medical school, Johns Hopkins. 433 black medical students, 573 white medical students. They were followed initially from 1958 to 1965, and they recorded information about diet and family history, family health history, background, habits, exercise, all those types of things. And they revisited this same cohort, or these same two cohorts, in the 1980s and tried to assess who had gone on to develop hypertension. And what they found was that all of these physicians were people who experienced a great deal of stress in their profession. But even within that as a baseline, you could find that there were racial distinctions in terms of who was more likely to develop hypertension and some of the health detriments that come from that particular disorder. And so again, we see that as we are taking care of physicians, we have to be mindful of how some of these underlying isms that we are constantly dealing with play out, and how we need to have strategies that take this into account as we look at ways to create and sustain physician wellness. The last, maybe I have two more, study to look at was specifically in Native American population and looking at diabetes. This was from Sittner et al. And published in the Journal of Behavioral Medicine about 3 years ago. They looked at 194 Native Americans with type 2 diabetes and then did a correlation with the microaggression survey and the diabetes distress scale. And they noted that the Native Americans who reported experiencing microaggressions were more likely to have poorer control of their diabetes and less likely to engage in self-care and behaviors that promoted health. And so again, we notice that the microaggressions themselves, even though the terminology is not incorrect when we call them microaggressions, I do want to be clear that these have demonstrable harm. They actually do cause a detriment to the people who experience them. And that is a part of what we have to consider and focus on when we begin to try to look at wellness. Another way in which I think this is actually a form of a microaggression, but this concept of resilience has been emerging and advancing, I think, lately. And we have this notion that the way in which we can help create physician wellness in particular is to give physicians better skills to cope with their adverse circumstances. And so we look at things like navigating their long work shifts and lack of resources and dietary things and heavy workloads. And we say that one of the remedies for that is to do more yoga, eat better, get more rest, do more exercise. And I think that conceptualization can easily go astray, and I'll talk about that in just a moment, because the focus really becomes more on finding coping mechanisms rather than addressing the fact that the adverse circumstances might need to be changed to begin with. And I think that ultimately some of this comes down to creating and finding a balance of gratification from medical efficacy and a satisfaction from the altruism of doing the work with the ability to care for oneself and understand when the load that one is carrying is too heavy. And that needs to be addressed more so than how we breathe through as we're lifting the heavy load. And so that brings me to this concept of how is resilience sometimes used as a weapon. And I think this cartoon is one of my favorite, or excuse me, not this cartoon, this photograph is one of my favorite representations of this, because conceptually I think we all need to see and understand if too much weight has been put on the bar, we're just not going to be able to lift it. And so you don't need a coach to help you breathe more through your powerlifting. You don't need meditation, per se, to help you understand where the bar is and what the weights are and how they all feel. Ultimately, you need a spot. You need someone else to help pick up the excessive weight, or you need someone to come and take some of the weight off the bar. And so I just want us to recognize and understand that resilience is a wonderful tool. It is something that we can all develop internally. But externally, we also have to look at what we are asking people to do and whether or not it may be too much. And one of the points I want to make about this is that specifically bringing together diversity, equity, inclusion, and physician wellness, the underrepresented physicians often are the ones who are feeling like we just got into this game. We feel like we have opportunities that people who look like us very often don't have. And so there will be a very strong impetus in us to not give up and to accept more work and to just, put our heads down and power through as we've always done, and just keep working. Because again, there has been an entire career built for many of us on just proving people wrong and defying the stereotypes and proving our worth. But even that sense of industry can be weaponized, and to have us keep working when we really should take a rest, and to have us keep trying to take on more responsibilities when really we should be saying no. And so I do want to acknowledge and honor the concept of resilience, but also understand how that can really work against particularly physicians of color, so that as we again begin to craft our physician wellness strategies for the 21st century, we are a bit more inclusive. And again, I just want to touch on one thing. The underrepresented physicians, burnout is clear in many physicians, particularly today with all that has gone on with the pandemic and all that we have seen and experienced. But I want to, again, use this lens and this time to raise the idea that in addition to the burnout that all physicians are experiencing, minority physicians are also adding to this racial battle fatigue, and the ways in which, as we are dealing with the pandemic, we are also dealing with the death of Breonna Taylor and Ahmaud Arbery, and the racial unrest that is unfolding in this country, and the ideas that feel very much like Black Lives Don't Matter. I think that we have to be mindful of how all of this has come to bear in the minds of African American and Latino and Asian American physicians, and also our Native American and indigenous physicians as well, who have much smaller numbers, are dealing with more than just the, let's call it, regular burnout that physicians are dealing with. And so again, as we look for equity, we may need different boxes to stand on in order to get our feet back on the ground and to feel well and healthy and productive in doing these things. And so then, what's next? Well, we do want to move forward together. We want to have diversity, and see a wide range of people entering medicine and feeling comfortable and thriving. We started with looking at reality and where some people do bring some privilege to the game. Some of us start really in a deficit space and work our way out. But again, as I was saying, that mindset of always working your way out of the hole. We do have to be careful not to allow that to be turned against us, and sort of have us become these perpetual work engines that don't take time for ourselves and don't center ourselves and don't value and promote self-care. But ultimately, we want to move to the place where any walls that are there are down for everyone, and we can all enjoy these experiences together and have this truth of liberation. And then, we want to be with our C's, be in community, be inclusive, be connected, be contributing in a way that makes us feel good, makes us feel healthy, be contemplative and spiritual, and fulfilled. And again, that sense of shalom, peace, and feeling that what I am is enough. And then again, we want to be able to be comprehensive and inclusive, and expansive, bringing others along with us, creating wellness that can be enjoyed and shared in community. So what does change look like? Well, it looks like us saying, we see that physicians of color experience racism in healthcare. And so that is a point that we have to address in order to have wellness. Again, in this age of our pandemic, we see our Asian American colleagues experiencing significant backlash and Asian hate and myths, and being blamed for this global pandemic, and having to navigate completely hostile waters with patients telling you they don't want you to take care of them. These are the types of things that, right now, we can begin to look at what initiatives need to be in place. How do we raise up our allies? How do physicians stand together and say this will not be tolerated? And there is a place for each of us in medicine to help create this wellness for everyone. And so these are just the thoughts that I have about how physician wellness can be inclusive of diversity, equity, and inclusion initiatives and thought processes and understanding and perspectives, so that we create a wellness that can be shared, a wellness that can be experienced in community. And so I thank you very much for this time, and I am happy to answer any questions that anyone may have.